Hello, I'm Dr. Anthony Wheeler, and I'm going to tell you everything that you need to know about pathology. You're probably wondering what's going on in this image, all my budding dermatologists out there. This patient has mycosis fungoides. Now, if you don't know what that is, don't worry, we're going to get into it. In today's talk, we're talking about chronic leukemia pathology. This section is within your book. Make sure you have it handy. It has everything in it that you need to know, and it goes with these lectures. Now, chronic leukemia. Chronic leukemia involves leukemia of mature blood cells. Mature blood cells. As we can see in this image here, a peripheral blood stain. Notice the excessive amount of white blood cells, that's that marked leukocytosis. And there's all these granulocytes, neutrophilic precursors. Chronic leukemia is typically insidious in onset and visible in elderly patients. Examples of chronic leukemias include chronic lymphocytic leukemia / small lymphocytic lymphoma if it involves a lymph node. Hairy cell leukemia, you know that leukemia with the neoplastic cells that have those projections from their cytoplasm that makes it look like it has a little mini afro. Hairy cell leukemia. Also adult T-cell leukemia or lymphoma, and mycosis fungoides. Here's an image of chronic lymphocytic leukemia. Notice these smudge cells. You see those two smudge cells right there? Here's another example of chronic lymphocytic leukemia. This is specifically a micrograph of a lymph node affected by BCLL, showing a characteristic proliferation center in the right side of this image. Here's another image of chronic lymphocytic leukemia. You see these mature lymphocytic cells with somewhat of a scant cytoplasm and large nuclei. And this again, for the dermatologists, and for everyone basically, is mycosis fungoides. Note the skin lesions on the knee of this 42-year-old male patient with MF. And this particular slide is outside of your purview. It's here just so that you can recognize PDGFR, right? If you ever see that mutation, I want you to think eosinophils, okay? Here's another example of chronic leukemia. Now this you might have to know. And look at that panel D there. You see all those pinkish, hot neon pinkish, orangish granules and those bilobed nuclei? Those are way too many eosinophils. This is from a patient that has eosinophilia, specifically chronic eosinophilic leukemia. You can pause and read the rest if you want, but for brevity's sake, we're going to continue on. Now, this is super important. On the top, we have a karyotype showing 46XX with a translocation of 922. If you see that little 22 associated with A, it's a little shorter than it should be. And on the flip side, that 9 is a little bit longer. There's been a translocation. And you can see that on the FISH as well. FISH stands for fluorescence in situ hybridization. And it's a way for pathologists to actually see translocations or chromosomal abnormalities at that level. It's quite fascinating. If you ever get the chance to do it, I highly recommend it. But anyhow, keep in mind, this translocation 922 is associated with BCR-ABL fusion. Here's another image of a patient that has chronic myelogenous leukemia. And you can see this sample is packed with myelogenous cells from the myeloid lineage, such as neutrophils, promyelocytes, myelocytes, metamyelocytes, all those cells that eventually try to grow to neutrophils under normal circumstances. And as we can see here, with all these abnormal immature cells, something's definitely not normal. What mutation would you expect to see with this? You see all those eosinophils? I told you about it earlier. PDGFR, right? Don't forget that. It comes up a lot. PDGFR. Now there's A, there's B, etc. If you keep PDGFR tucked in your memory, you'll definitely know what to answer. So be able to recognize chronic eosinophilic leukemia. It's not as high yield as our rods or the other leukemias, but if you know it, hey, you know it. Now here's another example of chronic lymphocytic leukemia / small lymphocytic lymphoma. This will definitely come up. Keep in mind that if the lymph node's involved, that's a lymphoma. Also, as we can see, there are numerous immunohistochemistry stains that can be utilized. For example, CD20, CD23, pick up those B cells, CD5. Now we know CD5 is usually a T cell marker, but it's staining B lymphoma cells, and that's abnormal. And the Ki67 is utilized to see the proliferation index. The higher the Ki67 staining, you can think of it as the more malignant the lesion or the more aggressive the lesion. For example, Ki67 has extremely high proliferation index in conditions like diffuse large B-cell lymphoma. On the flip side, if you look at E, that's not very high staining. It's low. It makes us less worried. And in fact, chronic lymphocytic leukemia is quite indolent, right? It usually shows up in patients who are having surgery, typically a male, elderly male, like in his 50s, 60s, who's having some surgery and has a lymph node removed. The pathologist takes a look at it, diagnoses CLL, and guess what? The patient didn't even know. It's quite indolent. Here's another example of chronic lymphocytic leukemia / small lymphocytic lymphoma. Now we're looking at blood specimens, so this is specifically chronic lymphocytic leukemia. Chronic lymphocytic leukemia / small lymphocytic lymphoma, CLL, SLL, is characterized by B cells that co-express CD5 and CD20. Chronic lymphocytic leukemia / small lymphocytic lymphoma is the most prevalent type of chronic leukemia. It classically shows smudge cells and lymphocytes on blood smear. Small lymphocytic lymphoma is characterized by lymph node involvement, which results in widespread lymphadenopathy. Now, complications of chronic lymphocytic leukemia / small lymphocytic lymphoma are as follows. Patients might have autoimmune hemolytic anemia. They might experience hypogammaglobulinemia, somewhat increased risk of infections. And then there are the instances where this condition can actually transform into another type of lymphoma, specifically diffuse large B-cell lymphoma. And there's a eponym for that. It's called Richter transformation. And you'll probably be asked that. So if you have a patient with CLL, haven't been followed up for years, and they come back with all sorts of bead-like symptoms and enlarged lymphadenopathy, splenomegaly, have Richter transformation to diffuse large B-cell lymphoma on your differential. The leading cause of death in chronic lymphocytic leukemia / small lymphocytic lymphoma is hypogammaglobulinemia, compounded by an infection. You see these smudge cells? It's highly likely you will see them in the future. So make sure you know that these smudge cells, when you see them, have chronic lymphocytic leukemia on your differential. And again, we have a micrograph of a lymph node affected by BCLL showing a characteristic proliferation center. Be able to recognize this. Now, note with CLL, you'll have a number of small, monotonous basophilic cells. Those are the neoplastic lymphoid cells, okay? Here we have chronic lymphocytic leukemia at high power. And again, I'm making sure you got this. I'm making sure it hits home. We have CD20, CD23, aberrant CD5 expression, and a low Ki67 proliferation index. You know what this is? CLL. You got it. Now we're going to move on to hairy cell leukemia. Hairy cell leukemia is characterized by cytoplasmic processes that radiate from the malignant cells. You can see here, and there will be other images that are a bit more easy to tell, but guess what? Sometimes life isn't that easy. Sometimes you gotta really look hard and have certain issues and conditions and diseases and disorders on your differential, because in real life, diseases don't read the book. But fortunately, we can talk about it more. Now, hairy cell leukemia is positive, you need to know this, is positive for tartrate-resistant acid phosphatase, also known as the TRAP stain. Symptoms of hairy cell leukemia include splenomegaly, and this is caused by an increase of hairy cells in the red pulp of the spleen. And if a bone marrow biopsy is tried to be performed, the radiation oncologist or the hematologist oncologist or the nurse practitioner that's doing the bone marrow biopsies, whoever's doing the bone marrow biopsy might have a tough time, called a dry tap. That's when they do the biopsy and they don't really get anything. It's very dry. It's hard to aspirate. It's called a fibrotic dry tap. And that's due to the cytoplasmic processes actually impacting the ability to aspirate marrow elements. Now here in this image, you can see some of those hairy cell projections in the cytoplasm. Notice how those finger-like projections. We'll see some more. Keep in mind that patients with hairy cell leukemia typically don't present with lymphadenopathy. It's normally absent in hairy cell leukemia, okay? Hairy cell leukemia is treated by adenosine deaminase inhibitor 2 chlorodeoxyadenosine, also known as 2-CDA. The adenosine deaminase inhibitor 2 chlorodeoxyadenosine causes the neoplastic hairy B cells to accumulate adenosine to lethal amounts and fade away. Blah! 2-chlorodeoxyadenosine is also known as cladribine, aka lustatin. Now, if treated, hairy cell leukemia has an excellent prognosis. Now, here's another image showing hairy cell leukemia. Can you recognize the cytoplasmic projections? With regards to hairy cell leukemia, there are a number of stains that can be performed by the pathologist or hematopathologist to visualize and rule out other conditions, other lymphomatous conditions, so that the accurate diagnosis of hairy cell leukemia can be made. Besides the presentation and the physical exam, the notice of a dry tap, the proper epidemiology like an older Caucasian male, certain stains can be utilized, such as CD20, which picks up on the B cell markers, cyclin D1, annexin A, CD20, and importantly, BRAF V600E. You'll need to know that. Remember BRAF V600E for hairy cell leukemia. You got this. Wow, what's that cell in the middle there? That's a hairy cell leukemia cell. And you know that because you can clearly see the cytoplasmic projections, right? For extra points, what are these other blue things that are floating around? Platelets, right? And do you see all the RBCs in the background? Man, you're smart. Good job. Let's move on to adult T-cell leukemia/lymphoma. Adult T-cell leukemia/lymphoma is due to neoplastic proliferation of mature T cells, as we can see here in the right. This is a patient with T lymphoblastic leukemia. Specifically, the peripheral smear shows leukemic cells. Then there's a bone marrow aspirate showing leukemic cells that are small to medium sized. In C, we have the biopsy section showing the hypercellularity and all those basophilic cells. In D, we can see simultaneous translocation of both TCR loci. Now, symptoms of adult T-cell leukemia/lymphoma include rashes, generalized lymphadenopathy, hepatomegaly, splenomegaly, and lytic, aka punched out bone lesions. Also, there might be hypercalcemia. With regards to adult T-cell leukemia/lymphoma, T cells in acute lymphoblastic leukemia appear to be as blasts in the bone marrow smear. And keep in mind the T-cell acute lymphoblastic leukemia with deletion 7 and aberrant expression of myeloid markers may present. Here's an example of T-cell prolymphocytic leukemia. And here is another example of T-cell prolymphocytic leukemia. Note that we're looking at a peripheral blood smear showing medium-sized lymphoid cells with oval nuclei and visible nucleolus and moderate amounts of basophilic cytoplasm without granules. And this inset here on the bottom left shows lymphoid cells with a dot-like staining pattern with acid phosphatase. Note that CD3 is a pan-T-cell marker. So CD3 is used to make sure that this is a T-cell process. You can tell by positivity here, opposed to a B-cell process, which would utilize a B-cell marker like CD20 or CD19, something of that nature. But we have CD3 positivity on immunohistochemistry here, so we know it's a T-cell process. And here we have a patient's leg who's experiencing cutaneous involvement by T-cell prolymphocytic leukemia. So dermatologists and budding dermatologists, keep this on your radar. With regards to flow cytometry, know that T-cell prolymphocytic leukemia can be further proven, further supported by flow cytometry, showing bright staining with CD8 expression, uniform staining with CD52, and also you want to be on the lookout for CD4 expression to some degree. Those are key takeaways. I know this image here is probably too small to see, but keep in mind CD8 and especially CD4 and CD8. If you remember CD52, that's even a bonus. But CD8 and CD4 are T-cell markers. CD8 for the T killer cells and CD4 for the helper T cells. Here's a peripheral blood smear with lymphocytes. Note those cytoplasmic blebs in part A. And from B, we have a bone marrow aspirate smear with numerous lymphocytes. Note those prominent nucleoli. This is a patient that has adult T-cell leukemia/lymphoma. Now let's talk a bit about mycoses fungoides. MF which is the abbreviation for mycosis fungoides, is due to the neoplastic proliferation of mature CD4 positive T cells that infiltrate the skin. You can see that here to the right. Note that there's the presentation of classically seen Patrier's microabscesses involved with mycosis fungoides. Symptoms of mycosis fungoides include random skin rashes that may present as nodules and plaques, like you can see here on this patient's foot. Note that this was treated already. Patients may also experience fatigue and splenomegaly, or just hepatomegaly. The histology of mycosis fungoides is characterized by the malignant infiltration of neoplastic T cells into the epidermis that are known as Patrier microabscesses. And here we have the lesion from mycosis fungoides that you might see in your clinic one day. Here's some other images of the clinical findings associated with mycosis fungoides. Note that edematous dusky red to erythematous patches on the back and the left leg before this patient was treated. And in part B, you can see remission on the back and the left leg with addition of isotretinoin and methotrexate, as well as Sorlin plus UVA therapy. So the patient's getting better. Again, note this lymphocytic infiltration in panel to the left, marked A, into the skin, showing epidermotropism associated with mycosis fungoides. We have those atypical lymphocytes in the epidermis and a dense lymphocytic infiltrate with hyperchromatic nuclei in the dermis. Part B is just showing the results from a T cell receptor gamma gene rearrangement. Remember we talked about monoclonality? We were talking about various isoforms earlier and kappa lambda ratios. You remember that? Well, with T cells, that monoclonality can be found by assessing T cell receptor gammas, right? If there's too many of one form, we can say that there is evidence for a monoclonal process, which further supports the diagnosis of a neoplastic condition. Okay? See how everything just ties back together? We're building here. Wow, we got this. Now, Sézary syndrome is a type of mycosis fungoides in which those malignant cells actually get into the circulation of the blood. Here on the right, we have a malignant cell known as a Sézary cell with the characteristic cerebriform or brain-like nuclei. Do you see those folds? So make sure that you can recognize the cell because it shows up. On a blood smear, Sézary syndrome characteristically shows lymphocytes with cerebriform nuclei, and those are called Sézary cells. And another lecture completed. Wow. Can you believe we've gotten so far? You know so much. You're reading your book, you're reviewing your notes, you're answering the questions that I present to you. You're engaged, you're thinking. Wow, you're on the right track. You're going to do great on step 1. You're going to do great on your coursework. If you have any questions, comments, or concerns, let me know. Figure out a way to do that. I know you can do it because you're smart. And keep studying. And you got this. Talk to you later. Bye-bye.